Here we have Leo with us today. And Leo, feel free to introduce yourself and tell us all a little bit about who you are and where you're from.
My name's Theo. I am a vascular access nurse. So what that means is I deal a lot with needles. And as much as I always handle needles in the job that I do, I hate it on me, and my patients hate it as well. I work in the UK, specifically in London, as a vascular access nurse. I place PICC lines and midlines and occasionally ultrasound guided cannulas. I've been doing this for almost 6 years now, but I've been a nurse for about, I'd say, more than 10 years,
Yeah.
almost maybe. I qualified in 2009. I trained in the Philippines and I moved here to the UK to be a specialist. I am very much involved with infection control. I like making sure that the patients get a really great patient safety journey from coming into the hospital and through their discharge. And what that means with my job is that I try not to frighten them with sharp things. So there's a lot about making sure they're comfortable about the treatment they get. And it's all down to good rapport with patients and a lot of other things which we can talk about later.
Comfortable is not a word that most people think of when they think of needles, and I would love to change that. So I'm glad to hear you mention it. Let's get right into it. I guess when did your needle nightmare occur and what happened?
So I can never forget this one time when during the pandemic, I was starting my career as a vascular access nurse. And at around that time when COVID hit us really bad and everyone was getting sick, I myself got sick as well. I ended up being brought to A&E, and A&E or emergency room, they had to take a blood sample out of me, and it had to be an arterial blood gas. Now, the one who did my cannula, he did it really well. He managed to find a nice GC vein on my antecubital fossa, what we call it. And it's an 18 gauge, that went fine. The cannula stayed in for a good 4 days while I was in the hospital. But the arterial line or the arterial stuff that they had to do on me wasn't really that successful. So they tried at first. He did
Was it an
explain.
arterial line? They put one in and it stayed in, or it was an arterial
No,
poke?
it was just a stab really to get a sample of blood gas. And as you know, taking an arterial blood gas can be very tricky because unlike with putting in a cannula where you can see veins that are superficial, with the arterial blood sampling, they would sometimes rely on landmark technique and they would rely on the feel of it. So where they could feel a pulsation is where they would try to take a blood sample from, but they don't really have a good feel of the depth, of the size of the vessel that they're going to aim for. And so he explained that I'm learning to do this and that they were going to need to take a blood sample to examine how my respiration had been and the state of the oxygen and the carbon dioxide in my blood is. So, okay, I said, that's fine, go ahead. And unfortunately, they didn't get it the first time. And at that time, I already know how to do ultrasound guided cannulation. And in my head was like, oh my God, I could really teach you to do this. But
Plus, you
um,
knew those that use ultrasound that the artery is so much bigger than the vein in that
mhm.
area, anyways. I've thought that many times. This would be incredibly easy to get this artery. I'm going for this little bitty vein. So it's just fascinating that they don't use ultrasound. It could be done in a few seconds under
Yeah,
ultrasound.
I guess it's really down to what kind of training do we really have when we're learning to do these things? Are we still very traditional? And I appreciate that as much as we really want to be very proficient in doing these things, sometimes the resources may not be readily available. So that really got me thinking what happens if we end up in another pandemic and all of a sudden we have a surge of the requirement for doing cannulations or accessing veins. And we know that a lot of patients in the hospital are they don't have really good vein vasculature. Up to two-thirds of the patients that walk in the hospital are considered difficult venous access patients. What do we do with them? Are we prepared to actually provide a high level of care and a good patient journey to these, at least when they actually need it? So that really got me into thinking about that.
And in your case, you weren't even a difficult access, difficult intravenous access because they got your vein right away, no problem. You were a
Yeah,
difficult arterial access, which, or maybe you aren't, but
yeah,
that person just didn't have the skill and the tools.
yeah.
But I've never had an ABG or an arterial blood gas, but I have performed them on patients, and I have never seen any pain intervention used for that. I think
Mhm.
probably it's just not thought about as much, which shame on us and shame on me that I never thought about it. But from what I understand, it's extremely painful. And then also, I think with arterial blood gas, typically patients are pretty sick. So you must have been pretty sick. They were worried. And I don't know if that just overrides the fact that you still are awake and can feel pain. And but you're not too sick to be you still shouldn't be tortured when you're sick. And if you're really sick, maybe that's even more reason why we shouldn't torture you. And we're having breathing problems, it sounds like. And I'm sure that didn't, the stress of that poke and that attempt didn't in any way help your health. It harmed your breathing probably and made you more breathe more rapidly. And I'm just sorry to hear that. So did they get it on the second attempt, or did you use the ultrasound and get it yourself, or how did it?
So thankfully, they managed to get it on the second attempt. I guess it was someone who's more experienced who was able to do it. But as I was telling you, I was really close to saying to that poor guy, get an ultrasound. I'll guide you right here and then. I'll teach you where to go. I'll tell you which vessel to look for and what to aim for. But obviously, we can't do that because I'm not really well to do that, and I don't think I'd be in the right position to be doing it at that time. So I guess in my personal experience, when you mentioned about comfort and the pain that these patients experience, is that what I see is that we just tell our patients to it's gonna be a prick, it's gonna be a sharp scratch, and that well, in actual fact, it actually hurts. So I wonder whether there's actual pain relief and analgesia, as in if we're giving lidocaine as part and parcel of that process. So I guess it's one thing to consider really to make sure that we know it's not going to be as less of a discomfort as having a cannula, but actual arterial stabs can be very, very uncomfortable.
As part of my research journey here as a PhD student, I've been looking into all the different interventions that exist for in IV placement, but that can be translated to any needle procedure, which is why I've expanded to say, let's talk about all needle procedures. Arterial pokes hurt just as more, if not worse. And there are so many interventions, and I hope to continue to highlight that with this podcast because I gave a presentation a few months ago. There's over 20 that I've found, over 20 different interventions and ways. And it's interesting with lidocaine because if there's not really single dose use syringes of lidocaine that I've found anywhere that anybody's using, so you have to draw it up in smaller doses, and then
Mhm.
there's that barrier there of in an acute care setting, how to scan that and how to give that, and then are you wasting the rest of the lidocaine? Also, just it's one of the most used medications throughout the world. So if we start using it for every single IV, just the supply and demand of that, or every single arterial poke, and I think there is a time and a place for it for sure, but it's been so interesting to read about so many more studied. They've been studied for decades, these interventions that exist that aren't lidocaine that have been shown to be helpful. But it's again a time and a place, and everybody's different too. So again, I hope to highlight that as time goes on. But you're right. Something is better than nothing, and we need to at least think about comfort when we are poking somebody with a sharp object. It's
That's
going to
true.
hurt.
I fully agree with that. And It doesn't really have to be lidocaine. It doesn't always have to be pharmacologic. There have been interventions that we can use, whether it's analgesic spray or distraction, etc. There's also this device which I saw with and they use it in pediatrics where it mimics like a buzzing next to it. I think that's really good. And I think it's going to change in the near future because I've been approached by one manufacturer and they're doing single dose lidocaine prefilled syringes. So that could work very well in those
Mhm.
scenarios you just mentioned.
Oh, good. Because that's a barrier that I talk to about hospitals that do use that pretty routinely. There's so much more we could talk about, but I just really want to know from that experience, just did that change? You said it a little bit. Did that change your experience and your trust within healthcare since then? I know it's motivated you to do what you're doing even better, but has it changed as a patient? Has it changed your experience of healthcare and your trust?
Yeah, no, I think it was very humbling. And I realized how vulnerable patients feel when procedures don't go smoothly. My trust in healthcare didn't disappear, but it shifted. I became more aware of the gaps in training and preparedness, and it made me ask how ready are clinicians to deliver not just treatment, but the safe and dignified patient journey.
If you could redesign that specific experience, what would you change? It sounds like use the ultrasound, but what would you change about that so that it was not a needle nightmare?
Yeah, I'd like to say it's simple preparation and skill. If ultrasound guidance had been used, the procedure would have been safer and less traumatic. Adding structured training like competency checks and accessing the right equipment would have transformed that moment from stressful to reassuring.
It's interesting too because it's traumatic for the patient, and obviously that's my focus in my research, but no clinician wants to poke somebody and miss and cause pain. So it's also traumatic for them to fail and fail again. We won't know if that clinician even remembers that or what, but I remember my first ABG that I did and who was there and how it went. And luckily it was successful, but it was basically luck because I was learning on the job. But it's traumatic for the clinicians too. The primary victim is the patient, but it's traumatic all around. So it's a needle nightmare all around. So have you had positive experiences since then or before then of being poked and what made that experience different?
Well, thankfully, I had been well enough to avoid those. But when you get sent home test kits, I remember this one time when I required a teeny little bit of blood to just send out, and it's just a quick prick on the side of my finger. And I just stood there for the whole half an hour, just trying to push that lancet onto my skin. I just couldn't do it. There still is a trauma each time I try to go to the doctors, and if they wanted bloods, I would still look away, although I always handle needles. So I really salute my patients for being so brave and keeping their calm and still when I do these procedures to them. But I guess once you've had the trauma, it's a bit hard to change, really.
And it's so important because we are as clinicians, you and we're the ones causing this trauma to patients. It's healthcare induced trauma. The term I've found in my reading is suffering caused by care. So it's care that we are providing, quote unquote, care, but the care itself is causing suffering. And I think because it's such a quick poke, we just don't think of it as suffering, but it really is traumatic. Trauma and suffering go hand in hand. I'd love to know just advice that you have. You mentioned it before about skills and competency, but if we break it down to what advice do you have for the patients going through a procedure? What advice do you have for the nurses or clinicians performing it? And then advice for executives and system administrators in how to solve this problem. It's kind of a big question, but if you could solve it at all levels and give advice, what would you say?
I guess an advice I would give to the clinicians make these procedures less traumatic is always prioritize preparation and skills and don't rush, even if we're at the most emergent situation. And there's technology we can always use. So use that with appropriate guidance. Communicate with the patient, explain what you're doing, and treat every cannulation or blood draw as a moment of care, not just a task, really. If I were to share my thoughts to the policymaker, I would really want to make it clear that vascular access, it's not a minor detail. It's actually a lifeline. You need to treat it with the same rigor as medication prescribing. Invest in training, ultrasound access, and structured documentation. Patients deserve safe, standardized care, and clinicians deserve the tools to deliver it. And for the patients, if they're able to speak up, ask questions. If you're uncomfortable, let the clinician know. You have the right to safe care, and your voice matters in shaping that experience.
Yeah. We have a long way to go, but I'm hoping we can get there quicker by talking about this more openly, by letting patients tell their needle nightmares. And all of us clinicians, sadly, likely have needle nightmares as well because we're on both sides of it. So I just keep saying it's 2025 and we can do brain surgery with somebody wide awake and some people to space and do all these crazy things. And we can't figure out how to make the most common procedure in the world comfortable. And I think we can figure it out. We just need to prioritize it. And it just hasn't been a priority. So I'm so thankful that you are also fighting the fight to try to make this a priority for your patients in the ways that you can. Thank you for sharing your needle nightmare. I'm so sorry that happened to you. I just, on behalf of all healthcare people that don't care, but us people that especially do, I'm just sorry that there was trauma caused to you in our healthcare system. And you and I are in different countries, but this sounds familiar. It's a worldwide problem. So thank you for sharing your needle nightmare. Is there anything else you'd like to share?
I just really want to share that my needle nightmare became a turning point. So it just inspired me to advocate for change.
Yep, great. That's what we need. So